So now that we are through with acquired cataract, all the types, everything in detail about the surgery, everybody, let's move on to the other type of cataract. If you remember the classification, it was acquired and congenital. So now we start with congenital cataract. As we had noted in the classification, congenital cataract can be grouped into two. First is the infantile cataract, and the second group is the developmental cataract. Now, what is the basis of this grouping? So, if the opacities develop before 1 year of age, we say it is an infantile cataract. In infancy, it is developing. But if the opacities develop after 1 year of age, then we group it as a developmental cataract. Okay. Now the question that comes into my mind is whether the cataract is developing before 1 year of age or after 1 year of age. We are calling all those cataracts as congenital. But doesn't congenital mean present at birth? So how can developmental, which is presenting after 1 year of age, be developmental? See, that is the word. It is presenting after 1 year of age. The pathogenesis, the development of cataract is present at birth. You have the cataract at birth. It is just the opacity which is being seen after 1 year of age. I hope you are understanding. We don't say a disease is congenital only if it presents at birth, everybody. The pathogenesis, the development of the disease has started, everybody. In utero, you are born with that disease. When it presents, it may be different. It may present at 5 years of age. It may present at 10 years of age, right? I hope you understand. Now, what is the difference? Why are we differentiating it based on the less than 1 year or greater than 1 year? The answer lies in the fact that if there is infantile cataract, it usually causes severe loss of vision. Why? As it interferes with foveal fixation. Foveal fixation usually develops around 3 to 4 months of age. Now, what do we mean by this word foveal fixation? We are saying that there is severe loss of vision because foveal fixation is interfered with. So what is foveal fixation? See, all of us know that the image, the central vision is through fovea. Fovea is the most sensitive part of retina, highest concentration of clones, blah, blah. Right? So, does the brain know at birth that fovea is the point where the best image is going to come from? No. See, our brain is like a supercomputer. It works on data. Yes. So, whenever the infant is opening the eyes, the image is being formed at each point of the retina. By 3 to 4 months of age, our brain has collected enough data to be able to ascertain that fovea is the best point of vision. So from then on, the visual axis, the position of the eye is oriented in such a way that the light coming from the object falls onto the fovea. And this process is called as foveal fixation. I hope you understand the story. Yes. If a child has cataract before that age, it is going to affect the collection of the data. Yes, the brain will not be able to understand that fovea is the best part. So the child will never be able to achieve foveal fixation and hence never able to achieve the normal 6/6 vision. That is why we say it will cause severe loss of vision. I hope you understand what I'm saying here. Yes. So what about developmental cataract? We say developmental cataract will usually cause minimal loss of vision. Yes, minimal means the opacity which is present, that will not interfere with foveal fixation. You have already achieved that, everybody. So the loss of vision will be in proportion to the amount of opacity, and usually developmental cataracts are very slowly progressive and they are scattered. Okay. After we've understood the difference between infantile and developmental, let us start discussing the names of the congenital cataracts. Let us start with something called as blue dot or punctate cataract. Blue dot cataract, also known as punctate cataract. By the name itself, it is very clear that there will be scattered small opacities which are blue in color, dot-like opacities. Puncta is dot basically. This is the most common developmental cataract. That is the question. Or if the question is asked, most common congenital cataract. See, overall we are talking about without the grouping into developmental and infantile. If somebody is asking you overall what is the most common congenital cataract, again the answer is blue dot. Or this question can actually be asked in another third way. Most common congenital cataract that is visually insignificant. Visually insignificant. I hope you understand the language here. Because it is a developmental cataract, guys, that is why we are saying it is causing minimal loss of vision, and thus it is visually insignificant, will not cause loss of vision. Also remember, blue dot cataract is most commonly associated with Down's syndrome. Okay guys, done. Now moving on to the next name, everybody. A very important name, lamellar, also known as zonular cataract. The first important, most common question, this is the most common infantile, or I can say visually significant cataract. Instead of writing it at 2 points, I am writing it as a single point, everybody. Yes, because it is an infantile cataract, it will cause severe loss of vision. So it is a visually significant cataract. Most common visually significant or most common infantile cataract. It is associated with A, congenital rubella syndrome. B, it is associated with vitamin D deficiency, or lastly, it can be inherited as an autosomal dominant trait. Okay, everybody. So the mode of inheritance is autosomal dominant. These are the three associations. Even though I have said that the most common association is with congenital rubella syndrome, but please remember, congenital rubella syndrome, what is the most common type of cataract? The answer is nuclear pearly. So please remember two different questions. Lamellar cataract is associated with congenital rubella, but congenital rubella most common is not lamellar, it is nuclear pearly. Okay, don't get confused between the two questions. Read the question carefully if it is asked to you. Presentation. Lamellar cataract presents with opacity in fetal nucleus. This is important. Why is it important? Because it is telling you that the cataract started developing in utero. The nucleus is of 4 parts: embryonic, fetal, infantile and adult, based on the age when it is formed. So the opacity is in the fetal nucleus because the opacity, the changes must have started occurring when I was a fetus, before 8 months of age. Yes. Now, along with the central opacity in the fetal nucleus, everybody, spoke-like opacities are seen which are known as riders. Okay. So if you're talking about the clinical features, please remember a central opacity in the nucleus, the fetal nucleus, along with that spoke-like opacities. So if I draw an image for you, let's say this is my pupillary area through which my lens is visible. In the center, you will have an opacity because it is a nucleus cataract, a cataract which is affecting the nucleus. Then along with that, everybody, you will see some spoke-like opacities. small spokes, large spokes, something like this. And all these spokes, everybody, as we have mentioned, are known as riders, right? Now, I hope you understand this photograph. If yes, then let us show you an actual photograph. So the photograph that you see, everybody, this is of a lamellar cataract. How can you say so? You will be able to see very clearly that there is an opacity in the center. Along with that, there are some small riders. You will be able to see, make out. Yes, if I erase this blue color now, I hope you are able to make it out like this. See, along with the fact that I am marking it, you are able to make out here also, here also. Yes, so small spokes known as riders. Done, everybody? Moving on, the next, everybody, important congenital cataract that you should know is known as posterior polar cataract. PPC, posterior polar cataract. From the name itself, it is telling you the site of the cataract, posterior pole. If you remember the anatomy of the lens, posterior pole was the thinnest part of the capsule, everybody. Yes. Now, it has an onion ring, or what we can also call as whorled appearance. Onion ring appearance or whorled appearance. When we eat onion for salads, everybody, we cut it in rounds, yes? So we are able to see all the rings of an onion, everybody. Or if you're talking about a whorl, everybody. So basically we are talking about such kind of a shape, everybody. Okay? So this is what the cataract will look like. Very easy to recognize. Let's see the image. See here, everybody. I hope you are able to see that whorl. Yes? Are you? Whorl or onion ring. If not, everybody, let's see it the other way around. We already know how to see an oblique illumination. So oblique illumination, everybody, this is my cornea. This is my anterior chamber. This is my anterior part of lens. This is my whole nucleus. Where is the cataract present? Do you see, everybody? It is present on the posterior surface, the posterior capsule. So there are actually two clues. You can see the shape, or you can see even the oblique slit that is being presented in this image. Yes, guys. So that means it is a case of posterior polar cataract, confirmed. Now, posterior polar cataract is associated with Mittendorf dots, which are remnants of tunica vasculosa lentis. Again, we have discussed about this in the anatomy videos, everybody. Yes. Secondly, persistent hyperplastic primary vitreous, PHPV, persistent hyperplastic primary vitreous. This is a condition which we have discussed in the retina video. And lastly, it is associated with PITX3 gene mutation. And that's your posterior polar cataract. These are the three important types of or the names of congenital cataract that you can study. After you know this, everybody, what is important? It is important that you know the treatment of congenital cataract. So see, the treatment of congenital cataract will be slightly similar to the acquired cataract. We have to do a surgery. Yes. What are the techniques we prefer, everybody? ECCE techniques. That means, again, we don't remove the capsule. We are going to do that. We are going to remove the lens, but we are not going to remove the capsule, because at last we need to implant an IOL in this case also. Yes. But what is the difference? The difference is that usually the congenital cataracts are very soft in nature. So you don't need to break the cataract into small pieces. Instead, you can just suck or aspirate the lens or cataractus lens. So instead of breaking the lens into small pieces, we do lens aspiration. Along with lens aspiration, an extra step that we perform over all the other steps, everybody, the CCCs and everything, we perform posterior capsulorhexis. Don't get confused. We make the side port, we stain the anterior capsule, we create a CCC. Instead of nuclear fragmentation, we do lens aspiration. After we have done lens aspiration, everybody, we create a posterior capsular axis. Just like we create a CCC in the anterior capsule, we also create a window in the posterior capsule. Why? We have just studied what is the most common late complication of cataract surgery, PCO, posterior capsular opacification. In a infant, in a child, he has the whole life to live. We know PCO will develop. So we are preventing the PCO from occurring by already creating a posterior capsular axis. Okay, the same thing that we would have done via laser after that, we are doing during the surgery because we know that it is going to occur. Okay, so to reduce PCO. Okay, now when we do posterior capsular axis, there are chances that the vitreous, which is present behind the capsule, has now found a rasta, has now found a way to mix and come into the anterior segment. So to prevent that, we perform anterior vitrectomy also. So we are solving one problem, PCO, by creating posterior capsular axis. It may lead to another problem, that is vitreous leakage or vitreous mixing with the aqueous. So we are doing anterior portion of vitrectomy also. Now, lastly, we need to implant an IUL. Please see carefully. I am writing the word usually. Usually after 2 years of age. I am not saying it is mandatory to do it after 2 years of age. Again, surgeon's preference. Usually it is documented to be done after 2 years of age, but it is not unheard of that we can implant it even at 3 months of age for that matter. I hope you understand what I am saying. Yes? Now, the IUL that needs to be implanted, if less than 2 years of age, under correct IUL power by 20%. If 2 to 8 years of age, under correct IUL power by 10%. Please remember this. When you do biometry, you find out the power and you undercorrect it because the size of the eye is going to increase, the axial length is going to increase. So you need to take all those factors into account before you implant an IOL. And the basic formula goes undercorrection by 20 or by 10%. I hope we understand all the steps of the surgery. Yes? Now the main important question comes in congenital cataract, when to do the surgery. Should we do the surgery at 1 year of age, 6 months of age, 2 years of age? Yes, that is the $1 million question. What is the answer? The answer depends on simple factors. If the cataract is unilateral and there is a dense opacity, then I am worried. Why am I worried? See the word unilateral. That means in one eye, everybody, the vision is normal. In the other eye, light is not able to go inside. That means the retina is getting confused. Remember squint, everybody? Yes. So what will the retina do? The retina will stop seeing from the eye from where the image is not coming. It will lead to amblyopia. Yes. So may lead to sensory deprivation, amblyopia. Amblyopia means loss of vision without any cause. So we don't want amblyopia to occur. So basically what are we doing? We are doing it ASAP. We are doing it as soon as possible. 4 to 6 weeks of age. Okay? Before foveal fixation has developed, before amblyopia can set in. But if this was bilateral and dense, then we know that it is not going to cause amblyopia in one of the eyes. Yes, the vision is lost. Yes, foveal fixation will not develop. But at least it's not that one eye will be shut off. So we say we can wait a little bit, just a little bit. Surgery by 12 weeks of age. Okay, everybody. Now, moving on. if the cataract is unilateral and partial. If the cataract is unilateral and partial in one eye, but not a dense opacity. Still, what can occur over a long period of time? What can occur, everybody? Amblyopia. Yes. So instead of doing an early surgery, we say, let's institute occlusion therapy. I hope you remember occlusion therapy. Which eye is patched? Can be done till 6 years of age. What is the modus? If not, then please see the squint videos, everybody. Yes. So occlusion therapy is done to prevent amblyopia. We want to delay the surgery, but we also want to prevent amblyopia, right? So based on these factors, everybody, we decide the timing of the surgery. And that's all about congenital cataract. I hope you understand. Very small and sweet topic, everybody. Please remember the classification, infantile and developmental. Why is it there? The names of the cataracts and the differences in the surgery from the surgery that we do in acquired cataract, right? Now that we are through with the types of cataract, everybody, acquired and congenital, everything, let's do some small topics, some other conditions which can be there in lens. What is the important other condition? It is known as ectopia lentis. Now, what is the meaning of ectopia lentis should be clear from the name. Lentis means lens. Okay. What do you mean by ectopic? Ectopia, ectopic. Ectopic means away from its position. Away from its position basically means displaced. Yes. So I can say ectopia lentis is displacement of lens. The name. Yes. Now, what we should know is what are the causes of ectopia lentis. Number one, what is the most common cause? So the most common cause is not Marfan syndrome. Yes, it is not Marfan syndrome, as a lot of students end up showing. I don't know why. The most common cause is blunt trauma. Okay. Ball, fist. Yes. Second important cause is hyper mature cataract. Hyper mature cataract. I hope you remember the stages of the cataract that we had discussed. I am writing here, everybody, two answers. Most common complication of hyper mature senile cataract is subluxation of lens, which can also be called as ectopia lentis. Yes or no? Subluxation means displacement, going down. At the same time, if the question is most common complication of Morgagnian cataract, I know Morgagnian cataract is hypermature. That is why I'm writing it for you. If they've specifically mentioned Morgagnian cataract, then the most common complication you should not answer as subluxation. Instead, we answer as phacolytic glaucoma. Phacolytic or phacolytic glaucoma. Okay. So there are two different answers to two seemingly similar questions. That is why I've written them for you, and I hope you will be able to remember and answer them correctly. The third important cause is aniridia. Aniridia is absence of iris, everybody. Yes, WAGR syndrome. Fourth important cause is it can be familial. Family history is present. That means you are inheriting it. If you are inheriting it, it is autosomal dominant inheritance. Moving on, fifth cause. That is the cause that you like to say, everybody, Marfan syndrome. Marfan syndrome is a very important cause. Yes. Why is it important? Because the examiners love to ask this. They ask, what is the direction of ectopia lentis? See, I have highlighted only the fan part because that is what helps us remember the direction of ectopia lentis. So when you look at a fan, where do you look? Up or down, everybody? Up. So I will say the direction of ectopia lentis is superior, supero. Then when a fan is rotating, where does it throw air? Does it throw air inside or outside? Nasally or temporally, if I say outside. So I will say the direction of my ectopia lentis is supratemporal. So through the word fan, I can remember, or I can try to remember, the direction of ectopia lentis. Yes. What are the other ocular features? Other ocular features of Marfan syndrome. So very important feature is megalocornea. The corneal diameter becomes larger. Then cornea plana. The curvature becomes lesser, it becomes flatter. Hypoplasia of dilator pupillae muscle. So pupil dilatation is not present properly or completely. And lastly, I hope you understand Marfan syndrome, everything becomes tall and large. So the eyeball also becomes large. So the axial length of eye increases. When the axial length of eyeball increases, it leads to myopia. So these patients are highly myopic. Okay. Now, moving on. The next important cause of ectopia lentis, going back to ectopia lentis, everybody, is homocystinuria. Homocystinuria. Now, in this, I will highlight the word urea. From urea, if I can extrapolate, I think of urine. I know it's a very bad way to remember, but nonetheless, it is a way to remember. Where do you pass urine, superiorly or inferiorly? Obviously, inferiorly. Where do you pass urine, temporally or nasally? Nasally. Infranasal ectopia lentis. Howsoever bad it makes you remember. Yes. The other important clinical feature is loss of accommodation. Loss of accommodation due to zonular dehiscence. Okay, that's the other important common clinical feature, ocular feature of homocystinuria. Please remember this. Number 7. Another important cause is Weil-Marchesani syndrome. Weil-Marchesani syndrome. Again, in this question, the examiners ask you what is the direction of ectopia lentis. So I will highlight this word March. Don't think of the month March, April, May. No, I am not talking about the month. I am talking about the army. In army, the Jawans are said, march forward. From there, I get the answer. Where do you want to march forward? Where does the lens go forward? So I can say forward displacement. Or if I want to answer it in a proper way, anterior ectopia lentis. Yes. The other important feature is patient has short stature with short stubby fingers. This is not an ocular feature, but this point is commonly used in questions to ask about Weil-Marchesani syndrome. Okay. If we are asking about an ocular feature, remember it also causes microspherophakia, which we will discuss in a while here, everybody. Microspherophakia. But please remember, a short stature patient with short stubby fingers, the question is usually about Weil-Marchesani syndrome. Done? Now, let us complete the list of the causes of ectopia lentis, everybody. Number 8. The important cause is hyperlysinemia. Number 9. Sulfite oxidase deficiency. Number 10. Ehlers-Danlos syndrome. Okay, guys, these are the 10 important causes of a case of ectopia lentis. If you are wondering how will we be able to remember such so many causes, 10 causes, blah blah, you will be able to remember everything, guys. I remember them. If I remember them, you can. Yes, obviously you can. I just remember ophthalmology. You are 19 times greater than me. You remember 19 subjects, guys. You have the power. You just need to think that you have the power. Everybody can remember. You just need to read it and revise it over and over again. Don't overthink. Just study and you shall be able to remember, guys. Okay? Now, let us see a photograph of ectopia lentis, everybody. Let's see this photograph. What do we see in this photograph? In this photograph, we see in the periphery iris tissue. Okay? That means this must be my pupillary margin. Ideally, behind the pupil, we should be able to see the whole lens. Yes, pupillary area behind the pupil, whatever we see, should be filled with what? The lens. But in this case, what do we see? We see something unique. We see the margin of the lens here. We see that lens is present in this area, but in all this area, there is no lens. What is this trying to show us? It is trying to show us that the lens has dislocated in this direction, maybe up and out. Okay, everybody? So this is showing us that there is a case of ectopia lentis. If you look carefully enough, yes, you will even be able to see some white small threads. See, I am circling this part. In this part, you will be able to see some white fine threads. What are these, everybody? These are zonules. Can you normally see zonules in the pupillary area? No, zonules are in the periphery. In the center, there is lens. But because the lens has moved, that is why you are able to see the zonules in the pupillary area. Yes? So that is how you recognize this photograph. If we say in terms of theoretical sign, what is seen on examination? On examination, we see a golden crescent in the pupillary area. We see a golden crescent in the pupillary area. Crescent means moon shape. Can you see a moon shape? If not, let me erase this blue color and let's see. Can you see the equator of the lens, the edge of the lens, which is shining with golden color here, everybody? Yes. So this is the golden crescent. Chand dikh raha hai. Yes. Now, what does the patient complain of? Clinical feature, if I say. Patient complains of double vision. Why? Because now there are two areas of refraction. Here the refraction is occurring with plus 16 to plus 19 diopter. But here there is plus 0 diopter, so as to say. Yes, there is no lens power present here. So that is why there are two sets of light rays which are passing through the pupil. That is why there are two sets of images. One is forming normally on the retina, but the other is not forming on the retina. And that is why in one eye the patient has diplopia, double vision. Am I absolutely clear about this, everybody? Yes, that's all about the very simple topic, ectopia lentis. I hope you are able to remember the three important causes which are commonly asked because of the position of ectopia lentis: Marfan, fan, supratemporal, urea, urine, infranasal, wheel, marchesani, march forward, or anterior ectopia lentis. Right? Moving on to another small topic after ectopia lentis. It is a very simple topic, lenticonus. The name itself is enough. Sirf naam kafi hai. Conus. Conus means cone-shaped. And lenti means lens. As simple as that, guys. So what is lenticonus? Cone-shaped lens. Now, let's see the two photographs here. Let us understand whether we are able to ascertain what we are seeing, yes or no. Let's see the first image. Again, use your oblique illumination. Oblique illumination coming, this must be my cornea. This must be my anterior chamber. This must be my lens. Do you see some abnormality in the lens, everybody? Let me draw it for you. Instead of being convex, everybody, it has formed a small cone. On which surface, everybody? On the anterior surface. So again, if I mark it for you, this is how the shape is. So that means this is anterior lenticonus. Now let's see image 2, everybody. In image 2, what do we see? Now the light is coming from this side, everybody. This is your cornea. This is your anterior chamber. This is the anterior surface. There is no cone. But if I go on to the posterior surface, I see that a small cone has formed in the posterior surface. That means this must be what, everybody? Posterior lenticonus. So very simple, guys. Cone shaped. It is a shape disorder. The shape disorder can be on the anterior surface or on the posterior surface. So two types: anterior lenticonus or posterior lenticonus. And I hope you are able to identify them just by looking at the image now. Okay. Anterior lenticonus has three causes. The mnemonic becomes SAW. S for spina bifida. A for Alport syndrome. and W for Waardenburg syndrome. Posterior lenticonus has only one important cause, everybody, Loewy syndrome. Okay, I hope we are clear with the images. That is the main part here, everybody, and the 4 important causes that you need to remember: SAW for anterior and Loewy for posterior. That's all about the small topic lenticonus. Moving on to the last small topic, everybody. As I said, we will be discussing microspherophakia. Now, the name has 2 words. One is micro, the other is sphero. So basically, I have a small, micro means small, and sphero means spherical lens. Yes, small and spherical lens. Normally, my lens is biconvex and it's large. Here I am saying this is what my lens has become. Okay, you understand? Shape and size abnormality. What are the problems that will occur due to this, everybody? Due to microspherophakia, first of all, when my lens has become spherical, everybody, my lens has become spherical. That means the curvature of lens has increased. Yes or no? Something which was convex, now it has become spherical. That means the power of lens will increase. Increased curvature is equal to increased power. That means I will have curvatural myopia. Okay, so that's the first thing. Secondly, everybody, the lens is small. If the lens is small, everybody, it will start playing hula hoops. This is my pupil, my lens. It will say, let's try to jump through the pupil. It will say, let's try to jump through the pupil. But the pupil will not let it jump. When it is jumping, the pupil will catch it, everybody. So there will be what, everybody? There will be touching of the pupil and the lens. Aqueous will not be able to flow from posterior chamber to anterior chamber. Think about it, everybody, if you have seen the video of glaucoma. Yes. So small pupil will lead to glaucoma due to luxation of lens into anterior chamber, leading to pupillary block. Okay, you will be able to better understand this point if you have watched the video on glaucoma. So please come back to this if you don't understand it right here, right now, everybody. Yes. Also, because the lens is small, everybody, lens equator is visible 360 degree. Yes. So if this will be my pupil, everybody, I will be able to see the complete lens equator within the pupillary area when my pupil is dilated. I hope you understand this. That's all about microspherophakia. If you ask me what is the cause of microspherophakia, I will say I've already told you, everybody. Let me go back, everybody. We had already written that the cause of microspherophakia is Weil-Marchesani syndrome. So Weil-Marchesani syndrome causes 2 things: ectopia lentis and microspherophakia. So guys, that's all about the chapter lens from my side. If you understand the flow of the chapter, you know that you have to read it sequentially. Every piece of information is important to understand a little bit of concepts that are there in lens. Even though it is basically a factual chapter, but still everything can be connected to everything else so that there is a matrix which is formed in your brain and you are able to better learn it. Lens will usually give you questions, as already previously told. At least 2 questions do come usually, and easy questions at that. So I hope you read it once, you read it twice, and then never forget it.